Hello, everyone. I'm Brendan Hawker with Open Minds Market Intelligence Team, and I would like to welcome all of you to today's Circle Elite Executive Roundtable. It's entitled The Future of Person-Centered Care in California, the Pacific Clinic's Case Study. It's featuring Pacific Clinic's Scott Fairhurst, Vice President of Outcomes and Evaluation Analytics and Training, and Laura Pancake, Senior Vice President of Clinical Operations, Los Angeles South Coast Regions. Scott Fairhurst is a Vice President of Outcomes and Evaluation Analytics and Training for Pacific Clinics. In this capacity, he facilitates improving clinical outcomes by focusing on training and evidence-based practices, measuring clinical progress, and promoting a mission-driven culture of improvement. Having joined Pacific Clinics in 1998, Fairhurst has held various roles with progressive levels of responsibility, working with children and adolescents whose behavior was considered intensive. He co-authored scholarly articles and presented research at conferences across the country. Fairhurst earned a doctorate in clinical psychology from the University of Houston. Laura Pancake is the Senior Vice President of Clinical Operations for the Los Angeles South Coast Regions. She's responsible for the oversight of all programs, including health navigation, employment, training, and placement, substance use treatment, and housing. With over 30 years of experience, Pancake has co-authored research reports, including a study to reduce the early mortality of individuals with serious mental illnesses, published in the journal Psychiatric Services. She was also co-principal investigator in partnership with the University of Southern California to identify factors to rehabilitate individuals with schizophrenia. In 2019, Laura was named one of Los Angeles Business Journal's top women leaders in healthcare. She is a licensed clinical social worker and earned a bachelor's degree in psychology from West Virginia University and a master's degree in social work from California State University, Long Beach. Finally, moderating today's roundtable will be Richard Lewis, Vice President, Open Minds. As Open Minds Vice President for the Western Regions, Richard Lewis has extensive experience as a behavioral healthcare administrator, business development specialist, and innovator of new service lines. Mr. Lewis has served as a psychiatric hospital administrator, Charter Medical Corporation, and Assistant Director of Behavioral Health at San Bernardino County Department of Behavioral Health in California. Before joining Open Minds, Mr. Lewis has served as a Director of Strategic Development for Behavior and Addiction Medicine at the Southern California Hospital's Prospect Medical Group, Executive Director of Strategic Development and Planning at Pathways Molina Healthcare, and Vice President of Government Operations at College Health Enterprises in Los Angeles County. Mr. Lewis graduated with a Bachelor of Arts in Psychology from Whittier College. Before we begin, a few housekeeping reminders. Your audio will be muted for today's briefing. However, we encourage you to submit any and all questions you may have using the question box located on the right of your screen. We will present questions at the end and also try to work them in during if they're relevant. Finally, the slides and recording from today's briefing will be available on the Open Minds website by tomorrow. Richard, I'll now turn it over to you.
Thanks, Brandon, for that nice introduction. So welcome, everybody. And we can hold it that slide there, Scott. Want to welcome you to our second quarterly webinar. We're doing 4 this year that are focused on California providers, payers, behavioral health systems that are doing innovative programs, services, payment models. We're pleased that we're going to be featuring Pacific Clinics today to talk a little bit about their person-centered care, their person-centered care model, and the work that they've been doing for many years to really perfect this model and produce some really, really cool outcomes. Next slide. To put things in perspective, for those of you who may be outside of California, person-centered care is really a big thing for us here, as it has been nationally, as payers, both public and private, are moving more towards whole person care and value-based reimbursement type models. Now, California is one of the last, I think, probably one of the few still county-driven mental health systems left in the country. And we're in a process right now of moving away from cost-based fee-for-service reimbursement models for our Medi-Cal behavioral health system to more value-based and integrated approaches. Next slide. So we have a name for that, and it actually started 2 years ago. And the process here that's transforming our system is called California Advancing and Innovating Medi-Cal. We all call it CalAIM, and it's really designed to be able to, again, just transform our system completely from a fee-for-service model to more of a value-based approach to the provision of integrated services for behavioral health, addiction treatment, and primary care. Next slide. Just some key reforms. I mean, I think the big part of what CalAIM is doing here is being able to have managed care plans here in the state be more patient-centered focused, bringing in more population health management strategies that are built around whole person care type models to be able to integrate and provide delivery systems that provide services, on a whole person level. Again, addressing mental health, drug and alcohol issues, as well as primary care. 2021 was a big year for us because it was the first year under CalAIM that the managed care plans actually had contracts going with provider organizations to provide enhanced case management services for our SMI, serious mentally adult population, who are at risk for hospitalization and higher levels of care, as well as opportunities for providers to be reimbursed for 14 different types of in lieu of services type services, again, to address the needs of the high risk populations here in California. Next slide. So as we move into value-based reimbursement, patient-centered care is the cornerstone of value-based reimbursement. And we're seeing more and more models, not only nationally, but here in California, that are starting to move towards patient-centered care approaches that usually follow some basic guiding principles. Alternative payment models are driving patient-centered care delivery approaches that elevate participation of clients and caregivers in all aspects of decision-making in healthcare. We're seeing models that are including, that are actively pursuing health equity for all, the ability to engage in value-based payment models that advance simplified systems for consumers, really making it easy for clients and caregivers to be able to navigate their treatment and have a role to provide feedback. Organizations are engaging in continuous quality improvement measures, again, making it easier and creating avenues for feedback from clients and caregivers in their own care. And lastly, models that are effectively facilitating communication and data sharing are being designed that really make it more inclusive for clients to have a role and participate. All of these things that we're talking about here, we'll see in our case study today by Pacific Clinics, who've done an excellent job in developing the model over the past few years. With that, I will turn it over to Scott Fairhurst, who's going to kick off their presentation.
Thanks, Richard. It's been a busy year for Pacific Clinics. On March 1st, Uplift Family Services, founded in 1867, and Pacific Clinics, founded in 1926, merged together. And this means now we have over 2,000 employees. You can see here 25,000 Californians each year will be served by our larger agency. We're in 18 counties, and we're the largest community mental health center in California. We're the biggest. And with that comes the responsibility to do what we can to try to be the best. And whether it's behavioral health services or social services, foster care adoptions, or early education like Head Start and continuing adult education, or some of the support services that are essential to helping someone move from a model of decreasing their symptoms to living a valuable life. Now that, we can do more good stuff because we're this big, now we got to be sure we're doing good stuff more. So what does that mean? That means attending to person-centered care. And the Institute of Medicine published Crossing the Quality Chasm in 2001. And in it, they were calling it patient-centered care, but when they were discussing 6 cornerstones of quality, looking at safety, effectiveness, efficiency, equity, timeliness, and patient-centered care. So what did that cornerstone mean? It meant that it's the client's experience, not just satisfaction, right? Sometimes when we get into that triple aim model, we just think measure client satisfaction, then you covered the client's experience. That's your person-centeredness. It goes deeper than that. In fact, if you look at the middle box, you can see it's frustrating for a client who's unable to participate in decision-making because they don't have the information. And with that comes an interesting question. Whose data is it? And the answer is it's the client's. In order to participate, in order to be an equal partner in treatment, people have to have access to their own information. And looking down at that bottom box, you can see that's easier said than done. Everyone agrees clients should be informed decision makers. How are you going to do that? And so when Richard, I think, very generously said we've perfected some things, no, we haven't. We've taken some steps, though. We're getting there, and we're going to keep improving. So first, we have to try to build a way for people to be able to see their data and that clinical data and be able to see what does it look like. But, you know, if you build it, so what? I'll spend a second explaining what you're looking at here, but then I'll really try to emphasize how it's about bringing people to the data. Just a quick look at this for those of you that not as familiar with this kind of clinical picture. This is using the CANs, the Child and Adolescent Needs and Strengths. And what you see here on the top are the number of areas that need clinical attention, the number of areas that are either causing functional impairment or they're maybe dangerous or disabling. So you can see here, this is a course of treatment from August 2019 to August 2020, measured every 6 months, reassessed every 6 months in terms of how many of these clinical needs are present. And you can see that at intake, there were 3 clinical needs. And we'll just kind of take a quick look to see that impulsivity and hyperactivity was causing a functional impairment. School achievement was to the point where this kid was almost about to be kicked out of school. This was disabling. And the caregiver's residential stability was causing functional impairment. They weren't sure they'd have a place to live. There were 3 identified clinical needs at intake. In February, 6 months later, this impulsiveness and hyperactivity had actually gone from functional impairment to just something to keep an eye on. That's terrific. That's great improvement. The school achievement went from disabling to caught up. No longer an issue. In the residential stability from functional impairment to covered. Excellent. However, we learned some things 6 months into treatment, that the child was adjusting to trauma, that the caregiver had mental health issues that we didn't really know about at intake. And in fact, I'll just say a word about intake and the ability to kind of get information from a person-centered or client-centered point of view. And intake in large part is a trauma narrative. Think about it, right? Hi, we just met. Please tell me what you're like when you're at your worst and what are the hardest things you've ever been through in your life. When we first meet. And you know, when you learn about doing trauma narratives for people who have been through trauma, when you learn about that, you realize that there has to be a trusting relationship and there has to be some insulation, whether that's cognitive or affective, insulation that helps someone to be able to tell their story. And in intakes, we expect that to be done right away. Whoops, sorry. We expect that to be done right away, but come on, that's not how it works. And so here you can see these may have existed at the time of intake, we just didn't know it. We hadn't developed that trusting relationship. So this red line here is so that we can see, in fact, there were 5 actionable needs, 5 clinical needs that needed to be addressed: adjustment to trauma, impulsivity, school achievement, caregiver mental health, and residential stability. There were 2 present in February and 1 present, meaning that 4 were actually addressed. That's terrific. And this is a story that we want our treatment team, whether that's a prescribing psychiatrist, whether that's a clinician or a mental health worker, the client and the family, to be able to look together and tell the story. What's happened? What did we learn? Where did we get to? And what might help? And part of that, when we look at person-centered care, like Richard had mentioned, it exists at the individual level and at the organizational level. So for us, this has to address the fact that 25% or 26% of our families prefer Spanish. So this is for our clients under age 21. the families prefer Spanish. Well, then we have to make it so these dashboards, they're updated every night, but they've got to be able to be readable and understandable by our clients. Now, even with this, and I'll go back for a second, you can see we've got other languages here also, and we haven't built those automatically in. We haven't perfected it, but we're making progress. And so this would be an example of information we would share with the client and the family in a collaborative treatment planning meeting so that we could share the story together. Language is the first step, but participation rises and falls on all of these engagement activities. People have to know that we value their input in order to be providing input. People have to have the information in order to provide that input. And as we're telling the story of what happened, what might have helped, it's not just looking at progress. We also have to look at what other aspects of this past year have occurred. So sometimes we can tell the story through timelines. And it's kind of common in practice to say, well, how does it feel like the last year has been? And as soon as those words come out of my mouth, I think, come on, man, no one can do that. How has the last year been? We've got to have something to put that story onto. And so one of the things we track in that same dashboard, along with the client progress, is the amount of hours and minutes of services per month. And so the client and the family could look at this, and I'll even ask you, let's say you have a kid who is getting so far behind in school, in part because of the impulsivity and hyperactivity, but maybe also because of the residential stability and adjustment to trauma. What would stick out to you? And I'm willing to guess right here, May of 2020 would stick out to you because it's the highest. And you'd say something was going on. And in fact, here you can see 2.5 hours of after hours services. And you can see down here, starting at 6:30 in the evening for 2.5 hours. So from 6:30 till 9 p.m., there was an intervention. There's a story here in May of 2020 that our client and family, as well as our treatment team members, can tell. But there's also a story maybe here in June, July, and August. It went down lower. Being able to provide a visualization facilitates the conversation. It doesn't tell the story, it allows people to participate, provide information so that people can tell their story. What else do we look at? Well, for this particular kid, you can see that Ritalin was started in September, and then in November that was switched to Concerta. And that's a way to maybe connect that improvement in school. We saw how quickly that impulsiveness and hyperactivity changed from causing functional impairment down to something to keep an eye on. And the school achievement went from potentially disabling, right, at risk of losing the school placement, to no longer an issue. Kid caught up. But when we're looking here about med adherence, I actually want to make a person-centered comment on just that word. Med compliance is a non-person-centered word. What is compliance, right? And my clinical background is working with sometimes oppositional folks. Compliance means changing your agenda to match the agenda of an authority figure. We don't want medication to be like that. I don't want to take it, but they say I have to. When that's the dynamic, we're headed for trouble. Adherence means sticking to your own plan, owning the plan yourself. So here, when we think about what might go into adherence for a kid who's been prescribed Ritalin or Concerta, that's hard for a parent. And if any of you, in fact, I'm going to play the odds and say some of you do have a kid who has been diagnosed with attention deficit disorder and who has been prescribed medication. And in all likelihood, you had this internal debate for yourself or maybe within your family talking about, I think this medication will help him do better in school, but also might take a little of that sparkle out of his eyes, that impish twinkle that we all love so much, even though we know he gets in trouble all the time. It's a hard decision to make. And mostly with, the psychostimulants and Ritalin, the ADHD meds, families look at it like a phase. But here, when we're looking at person-centered care, means looking at the organizational level as well as the personal level. Here you can see I kind of looked at the organizational level for kids under 16 years old diagnosed with a neurodevelopmental disorder. For us, typically that's ADHD. Here you can see predominantly those are the meds. Now we can see that for some of them, some of the teenagers, we might see some antidepressant medications or even antipsychotic medications, some mood stabilizers, but ADHD meds are the predominant one. It's a different story though with adults. So for adults, looking at our organizational level, here you can see antidepressants and antipsychotics are the most commonly prescribed medications. Well, that's a whole different issue when it comes to adherence. What does that really mean for someone to decide that they're going to take an antipsychotic medication? Why does that matter to us? And in fact, we know one of the things that matters to us as we move into value-based care is this question of, are we tracking what we do? Are we tracking the results? And so here we look at one of the Hedis measures. And up in that top, in that sort of gray strip, you can see adults ages 18 through 64 who have schizophrenia and who are dispensed and remained on an antipsychotic medication for at least 80% of their treatment period. So question number one is, to what degree are we making that Hedis criteria? And here we can see meeting Hedis criteria, and we'll say it's about 84% of our clients ages 18 through 64 who are diagnosed with schizophrenia meet the Hedis criteria. We've been on an antipsychotic med for at least 80% of the treatment, meaning down here about 16% do not meet Hedis criteria. But okay, we can see of our 250 clients for whom we're tracking this, that's not all that have that diagnosis, but those are the ones for whom we have enough measures to see if they've been making improvements. Remember, we do our assessments every 6 months. For our adults, we use something called the MORS, the Milestones of Recovery Scale, and if they increase by 1 point, higher is better on the MORS. We call that improvement. If they decrease or stay the same, no improvement. But what you really notice here is, well, there's not much difference. For those who meet the Hedis criteria, not much difference in terms of improving or not improving. For those that don't meet, not that much difference. And in fact, I'm going to go back to crossing the quality chasm for a statement that seems self-evident, but then you got to kind of take a second and figure out what it means. And the statement goes like this: the ultimate measure of quality of a healthcare system is whether it helps. Of course, everyone would agree with that. But then what you realize is that takes the focus away from our activities, what we're doing, and it turns our focus to what leads to a result. Instead of finding ourselves in a position to say, well, you know, we prescribe the meds, the rest is up to them. Well, you know, there's a difference between addressing the deficits or addressing the symptoms and helping someone to lead a fulfilling life. Well, what goes into that? Well, part of that is just health. And at our organizational level, when we look at our vital signs, for example, we know that physical health connects with your ability to lead a worthwhile life, obviously. And, you know, as we're looking here at this pie chart, and I just looked at, you know, over the past couple of months for our blood pressures, this is for adults who are being prescribed medication, probably your eyes go right to that small pink line right there that shows 3 clients in hypertensive crisis. That's a risk, that's a danger, that's a potential stroke. And so, well, what does that also mean at a person-centered care? And in the way that this dashboard has been designed, and I want to acknowledge the person who built it, Neil Getcha, who works closely with another programmer, Alice Liu, who has really made these dashboards feel clinically relevant for us. The way that Neil built this one is so that when we click on that section, we can find out who's the clinician. And then once we go to from the clinician's caseload, we can take a look at the client's progress. And this is one of those 3 clients. This is the blood pressure. Well, if we are including the client in their information and helping them to look at it, suddenly we're saying something different to them. We're asking them, what do you notice? And I'll ask you, what do you notice? And for most of us, we will say here January, February, March of 2022, we would say, oh my God, this is dangerous. This is like a real problem. And this is one of the areas absolutely that should be focused on. But then, you know, you start to put your eyes over here in, what is this, November of 2021. And you say, this is close to normal blood pressure. There, here it is again in June of 2021. Here it is again, right? And this then leads to the types of conversations with the client that are more likely to promote med adherence. For this particular person, I know that they had stopped taking their blood pressure medication. Med adherence is person-centered. Med compliance is having someone change their agenda to match the agenda of an authority figure. It's about teamwork, and who's on the treatment team? Everybody, and that includes the client. And it's not just physical health, it's also, I mean, do you have a roof? So we've got 400 adult clients with no identifiable residents. And here you can see that there are maybe different circumstances and specifiers with that. But here you can see 150 people who consider themselves to be a street person as their residents. Well, that changes things. That changes not just the way we work with the client and part of the team, but that has to change in terms of the way that we structure our agency, the way that we look at what does it take to help someone. The ultimate test of the quality of a healthcare system is whether it helps. So we've got to change. We have to do something about that. And we can look, you know, we've been looking here at the agency level view. Sometimes I've been showing the client level view. Maybe the view we would look at might be for our employees, a supervisor. In terms of the employees, that supervisor is helping to guide. And these names down here are not client names, they're employee names. And these are employees who are working with this one supervisor. And this one supervisor, 2/3 of the clients that they work with are receiving some form of housing services along with mental health services. Whether that's permanent housing, pre-permanent housing, temporary housing. In fact, only one of the employees that this person supervises is working with people who are exclusively receiving mental health services. For the others, they're receiving some combination. I should say just a little bit about why it's more than 100%. That's because a given client may have gone from pre-permanent to permanent housing. And that's why this is not to indicate this person gives 150%. Not like that. It's looking at the services they receive. But that's the trick, right? The ultimate measure of the quality is whether it helps. So you got to build it. I mean, the right of clients to be informed decision makers is well accepted. The trick is implementing it.
So the question is, how do we move from what's necessary? How do we take the data that Scott's team provides to us, that we discuss together, that we discuss with the clients, and how do we build the services to ensure that all of their needs that they have identified and that we've identified are being able to be addressed? And how do we provide them with true whole person care? So in over the many years that we've been working in this, we've identified 4 primary areas. This will not be news to you, that must be addressed for people to be able to move forward in their recovery from mental illness. The first is securing a safe home. The second is learning to access and utilize healthcare independently and successfully. The third is establishing a meaningful role in the community and feeling connected in their community. And the final one is learning to live substance-free. So I'm going to shift gears a little bit, and I'm going to talk about the services that we provide. I am not going to go into detail about substance use. As we know, that could be a week-long presentation and is extremely important. I'm going to focus on 3 others that we specialize in that many agencies may not, to provide some guidance on how we've done it at Pacific Clinics over the last several years. So the first question we ask is, who should receive services and when? And traditionally, services were very, in mental health and other services that address determinants of care are very, very separated and disjointed and non-coordinated. They're also sometimes only provided to people who are doing well and who want the services. So we follow these principles. First of all, these services that I'm going to discuss in a minute should be provided at any point in a person's treatment and recovery. Again, we're not waiting for them to stabilize and get better. An example is in employment services, those are offered day one as soon as someone comes in the door. And that doesn't mean you need to go get a job right now. It means talking to them about their interests, skills, and ability and what they miss from their life prior to becoming ill. And as you can imagine, that really drives recovery, right? The next is they need to be provided to all age groups. All ages are impacted by their health and their living situation, and everyone wants to know, where do I fit in the community and how do I connect to people? They should be provided via a full comprehensive continuum of care so that clients can move back and forth between levels of care very smoothly without leaving their team, without having to go to another provider, and without having to, and that keeps them from falling through the cracks, right? And then the last piece, which will sound familiar to many of you, is having a specialized service provider who is fully integrated into the team. And again, individuals do not have to leave and go to another disconnected team to get these services. So housing first. Housing first is great. Everybody believes in housing first. We have to do it. But the question is, what comes next? And so we have a very comprehensive housing program I'm going to talk about in a minute. But what we find over and over again over the years is that someone will be placed in housing and that the housing is then highly jeopardized due to life-threatening health issues, inadequate income and living in poverty, a lack of engagement in their community, and then substance use. So we have, I'm going to cover our employment program, our health navigation program, and our employment services program. And I'll show you how we've done it and built it over the past several years and how we recommend others do. And what works. So for our housing continuum, we do the full continuum. And we start off, of course, with outreach and engagement to individuals who are homeless and provide them with emergency housing placement. And then we have several properties where we, and facilities where we provide temporary housing and support services. This is not as popular as it used to be. The funding is not necessarily geared towards this coming from the state of California, but we believe that this is extremely important. So this is where someone can live for 1.5 to 2 years. They still maintain their criteria for being homeless with HUD, and we help them develop independent living skills. They get the full continuum of mental health services while they're there. And they also, of course, receive intensive help to secure a voucher and to find either, sometimes they'll return to a family, but usually they're finding permanent independent housing in the community. The next piece, as I talked about, is the linkage to permanent housing. And then when they reach permanent housing, we need to, of course, work on those independent living skills, provide support for Section 8 visits, for hoarding, and how to cope with hoarding and move past hoarding. Also, how to communicate with your landlord, how to pay your rent on time, all of those things. But the goal here is, by building this full continuum, we've eliminated hopefully people falling through the cracks, right? We're not sending them somewhere else to get their voucher. We're not sending them somewhere else to live necessarily, but we're helping and following them in our agency through all of the phases. So next, Scott. So now I'm really excited to talk about our peer health navigation project bridge model. So in 2008, we developed this model in partnership with the University of Southern California School of Social Work, and Dr. John Brecky and I led this initiative. And what we wanted to address was the significant healthcare issues of people with severe and persistent mental illness. So as you may or may not know, people with mental illness die on average 25 to 30 years earlier than the rest of us. And this is due to a multitude of factors. But some of the primary ones are that they do not get treatment for preventable and treatable illnesses. Oftentimes, these illnesses are caused by their psychotropic medications, high blood pressure, high cholesterol, heart disease, obesity, and they do not access primary care providers. They simply don't get the health care they need. And so it's something that can be fixed. It's something that can be addressed. So we developed this model. We chose to train peers to do this, peer providers. When people are addressing healthcare, it's very, very frightening. I'm sure some of you experienced that where you haven't been to the dentist. I talked to a colleague who hadn't been to the dentist since before the pandemic. She was a little scared about going. Those of us who are, oh, I'd rather not know than find out I have cancer. It's like, I'll just sit back here and wait. So you can imagine with our clients who haven't been to the doctor in decades, this is very frightening. And we find that peers who have that lived experience in mental health as well as physical health are able to engage them much better. But we also train and focus on people who are not licensed and not clinicians, but are paraprofessionals. When we developed this training, we found that there was a big gap there. There wasn't a lot of structured training or full training for people who were case managers and peer partners. So it is a comprehensive healthcare engagement and self-management intervention. And what do we mean by that? So through the intervention, clients are connected to all areas of healthcare, as well as substance use and specialty services, including dental and vision care. A big focus is helping clients engage successfully with a primary care provider. Many people gave up trying to utilize primary care providers because of the arduousness of trying to do that, but also the stigma that exists in the primary care environment. So an example is we had a client who met with their psychiatrist and they had a rash on their arm. So, and this is a true story. So the psychiatrist says, you should go to your primary care provider and get that checked out. They go to the primary care provider, and the primary care provider saw that they had a diagnosis of schizophrenia and said, you need to go back to your psychiatrist. I don't want to deal with you. We have story after story of this, of people with breathing issues and a diagnosis of anxiety disorder. Well, that's part of anxiety is shortness of breath. No, in fact, the person had a tumor, a cancerous tumor that they had lived with for many years and unfortunately passed away because primary care would not address that with them because they dismissed them and deflected it to the mental health diagnosis. So when you have those kind of experiences, you're not going to go to the doctor, right? And then the last one is, unlike traditional case management or care coordination, we're teaching people in this model how to be assertive self-managers, advocate for themselves, and then access and utilize the healthcare on their own. So it's corny, but you'll see in this model, as well as employment services and housing, in all of those, we are teaching people to fish. And that, I believe, is the absolute key to move people through our services, through our system, and help them establish themselves in the community so that we can free up the capacity to serve more people. Okay, thanks, Scott. Next slide. So just very quickly, some of the core critical elements of peer health navigation. I talked about the consumer screening and engagement. Often they are very, unlike housing, where if you say, do you want housing services? People will say, absolutely. Right now, with healthcare, they're very hesitant to do it. We do a full evaluation of their physical and mental health care. And then we do goal setting. And they usually have 2 goals at minimum. One is healthcare. The vast majority are often managing my diabetes, but also getting some health screenings so that I can address other health issues. And then they may have, they also establish a wellness or lifestyle goal. And so I don't know if you know, but 40% of the cigarettes smoked in the United States are smoked by people with mental illness. So smoking cessation is a huge goal here. It has massive ramifications for health, as we know. And also it could be, I'm going to walk a few blocks, or I'm going to get connected with a dietitian or nutritionist, and the health navigator facilitates and helps them with all of that. Then we help them prepare for the medical appointment. This is making the appointment, sitting on hold. I sat on hold for an hour last week trying to get an appointment for one of my children, and tolerating that stress of our healthcare system right now and how to access care. Also using a form called the Ask Me 3, which we did not invent, but we borrowed and adapted, where in those 15 minutes you've got with your doctor, what are the 3 things you want to ask? I've been using this form with myself and my children since 2008 when I first discovered it, and it is incredibly helpful. The doctors, the primary care providers also have given us a lot of feedback that they really like when clients come in with that, because particularly our adult and older adult clients have a really hard time communicating, and it's very anxiety provoking. And how do they communicate clearly their needs? The next one is navigating the medical appointment. So that could entail going and sitting in the waiting room with people. Again, very long wait, could be an hour and a half. How do you tolerate that? How do you take care of yourself in the time of COVID? How do you stay safe? How do you communicate with that front desk staff who may not be having the best day because they're really overworked? And then accompanying the person into the exam room if they want that, so that they can actually absorb what the doctor is saying, understand what the doctor is doing. And then very, very important, reviewing the appointment afterwards and the follow-up care plan. So what we found, there's some statistics of how all of us, there's a huge amount of medication that sits at a pharmacy that all of us have been prescribed and no one goes and picks up. And so for our clients, it's the same. They're not picking up their prescriptions. They're not following up on specialty referrals. They're not getting screenings that are recommended. So the health navigators work with them on that. So our mantra throughout this whole model is very simple. It's for them, with them, by them. So first we do it all these stages with them. First we do it for them, and we're modeling for them. And they're watching us make the phone call and making the appointment. They're on the line with us. Then we're doing it with them. They're making the appointment. They're going to the appointment, and we're sitting back and not taking a really active role and helping and coaching them. And then finally, they're doing it for themselves, and they're doing it. It's the by them piece, and we are sitting and checking in with them during that process. How did it go? And providing some feedback. So we've done multiple randomized controlled trials around health navigation, this model. And Scott, you can move to the next slide, please. And our outcomes have been really fantastic. So the first one that I wanted, and this is one of the studies that Brandon mentioned that we had published, and you are welcome to look at that. So one of the first ones, and probably the most interesting to people, is this significant reduction in emergency room visits and urgent care, which of course we all know immediately and directly translates into cost savings. So in a couple of our studies, the inappropriate emergency room visits decreased to 0. We eliminated the person, which many of our clients fall into this, going to the emergency room because they don't know where else to go, and they may have a cough. They might need their meds refilled. They're just not feeling well. And so they go. We had a couple of transitional age youth clients who said, oh, well, this is where my parents took me. We didn't have a pediatrician or doctor. We just went to the emergency room for everything. And so that's what they are in the habit of doing. So as we connect them to primary care, they see that the experience is much more pleasant, of course. It's not an 8-hour wait, and they can go in very briefly and get their needs met. So we saw a huge preference for the use of outpatient care. Another really significant finding, which I felt ridiculous. I'd been in adult mental health for 1 million years, and I'd not thought about the significant pain, physical pain, that our clients are in every day. It is tremendous. Joint pain, abdominal pain, chest pain. So they're dealing with their mental illness. They're also dealing with significant physical pain. And if you walk away from this presentation with nothing else, please remember that as you're interacting with someone who has a mental illness. We saw a huge reduction in that, of course, as they got their physical health care addressed. And then the last really significant finding that I loved, was very relieved about is we found that they maintained the skills that they had gained through the intervention for 6 months after, and there was no loss of improvement. So that was tremendous. Yes, they can learn it, but can they maintain it? And I want to point out in these studies, the people we were teaching, by and large, had schizophrenia and schizoaffective disorder and bipolar disorder. These were people who we would consider in our, in our system to be the most ill. And they were coming from full service partnership, very intensive case management programs predominantly, from all different groups. So we chose the hardest population and it worked. And then lastly, they were able to generalize these skills to substance use as well as employment, which was fantastic. So I'm going to go get my substance use services, I'm going to get a job, and I'm going to use the skills I learned here. Okay, next, Scott. And then just briefly, we then adapted the model, Pacific Clinics did, and developed family health navigation. And this is for families and caregivers so that they can effectively advocate on behalf of their child, also learn how to help their child make it through a medical appointment, and also providing a lot of health literacy. There's a huge gap in that, and that impacts the health care that children are getting. So we provide that as well. Next. Okay, so I'm going to get on my soapbox just for 5 minutes. So if you want to know how to move people through the system and help them recover, I'm going to tell you now. You can do everything you can, get them a job, help them get a job. So work is treatment. That's the philosophy that we've follow. I've been doing this for 30 years. And what we found, again, in our work and studies with USC is that it decreases fear and social isolation. It improves self-esteem, and getting a job facilitates, of course, social connectedness and integration into the community. So guess what? All of those reduce symptoms. And so it's so inexpensive. It is not rocket science. It's easy to do. And right now in this world, as you all know, you're struggling with workforce issues. It is so easy to get a job. But we've been doing this in all types of economies, and people want to work. So only 15% of the population with mental illness work. But if you interview them, and first they say, and you can move to the next slide, Scott. If you ask them if they want to work, they'll say no. And I'm going to tell you why, because they're afraid of losing their Medicaid, their Medi-Cal, and their benefits. But in fact, they won't. Lots of changes were made many years ago around this. A lot of service providers still think that's the case. And when you say to them, take the benefits out of the equation, you won't lose them. Do you want to work? A significant number, 65 to 70%, want to work. So they're dealing with mental illness, physical health issues, and then if anybody's been unemployed involuntarily, it is extremely depressing. Leads to a lot of symptoms that are very similar to mental illness. So they kind of have the triple whammy going on. So what are you going to do? First of all, there are 2 extremely well-established evidence-based practices. You can get the toolkits from SAMHSA, supported employment and individual placement and support, which is kind of the second generation of supported employment. We implement both depending on what our staffing looks like and the needs. But the core principles of these are: 1, you're going to introduce employment right off the bat. This is normalization. Yes, you can get a job. Well, I just got out of the hospital. I just got out of jail. That's okay. Could be in 6 months, but we want you to know that we believe you can work and can get there. We saw when we did that the number of people who eventually got employed skyrocketed. It was tremendous, the improvement. And then you also want to tailor the employment services to their stage of recovery. Again, I just described that. If somebody's further in recovery, they're ready to go get a job and open to it, great. And then you want the employment specialist, just like a health navigator and just like a housing specialist, fully integrated into the treatment team. If you can't afford a separate person, you can cross-train them and teach them some of these skills. A lot of it is billable. We're not calling employers. We're not saying, can you hire my person with a mental illness? We have a different way of doing it so that it is billable. And then we're going to talk about benefits planning and how to protect your benefits. And of course, it should be time unlimited. They're going to come and go. People with mental illness come and go. They are doing well. They need some support and come back. Okay, so for all 3 of these approaches, housing, health navigation, both family health navigation and peer health navigation for adults and older adults, and employment services. At Pacific Clinics, we developed our own certification process. So there were some peer certifications, there were some, mental health worker or specialist associate programs. There were people coming out of school with their degree in social work or psychology. But what we found was there were not specialty trainings for this level of staff. And they were very hungry for it, and we needed it. So we, through our Pacific Clinics Training Institute, we provide housing specialist certification, the peer health navigation, family health navigation certification, as well as employment services certification. And what we do in all three of those is that we, one, make sure it's billable. That's one of my rules. If it's not the world we live in, if it's not billable to Medi-Cal, we can't do it right now. Hopefully that will change. And two, the supervisors involved. So thank you so much. I'll turn it back over to Richard as we end the session, but hopefully that was helpful.
I'm on mute. Sorry about that. Thank you, Scott. Thank you, Laura. Before I do have a question, but I wanted to, in the last few minutes that we have of the session, to see if we have any questions from the audience. Brandon, were there anything that came through while we were presenting?
Truthfully, we've not had anything come up. So
Okay.
your guys' presentation, I think that's, just how great your presentation's been and how informative.
Okay. Well, I do have one question, and that is, all of this is new to me, and seeing the model that you've put together and your use of data. How did you train or get your clinical staff to embrace the use of data? I mean, it's you don't hear that very often, and I'm just curious, was there what was the training like? Did it take years? I mean, how did that work?
I'll probably change the verb tense from the past tense to the present. We're still doing it. I think a large part of it came from modeling, so that, for example, when Laura is leading a meeting and she'll, pull up a visualization or ask me to pull up a visualization and walk people through it, or build CQI projects that require using the data. In order to help our direct service employees use this data and share it with the clients, we have some people that bought in really quickly and loved it and were able to kind of make sure that every conversation was clinical, even though it kind of was data put up on a dashboard. There are other folks that we're still trying to help bring along to that process. And it's continuous outreach. In fact, I try to watch how often I use terms like data or numbers, because I think people have this kind of 7th grade flinch that they still go to, or this college stats class flinch that leads to a little bit of avoidance. So we can just say, we're just trying to help you be able to see it. And I think it's ongoing, and I honestly don't expect that part of engagement to ever stop. We're trying to keep bringing people to the data.
And also using it, I remember several years ago, and going back to the CANS dashboard that Scott shared, and watching him use it in a team meeting with his staff was absolutely incredible. So incorporating it into collaborative plan development, incorporating into team meetings, so that the supervisor is just, and it's particularly easy now that a lot of the meetings are virtual. It's so easy to pop it up. So I'll be talking about a topic in one of our leadership meetings, and Scott will just immediately, if I say, yes, we need to decrease telephone services, and then Scott will be able to pull that up. He'll be able to drill down, see how we're doing, and it's really propelled a lot of our improvements, particularly over the past 2 years through the pandemic, as things changed so much. It's been incredibly helpful and important.
And do you, and maybe it's something you're planning on doing in the future, do you have any outcomes around this model, data, housing, employment, as part of your patient-centered approach that shows, increased residency in housing and not falling out of treatment and those types of, those are things we hear a lot about, especially when we're working with a complex population that you're working with, is that treatment and housing, there's a lot of obstacles and issues that go there. It sounds like your approach has shored up a lot of those gaps, those gaps that where clients are falling out of housing and out of treatment, blah, blah, blah. Do you have any outcomes related to the success of this model in regards to those things?
So what we've seen is the number of people who are placed in and maintaining permanent employment has just continued to grow and grow and grow and grow. Yeah, on a consistent basis as we shore it up more and more often. And then looking at the demand is so massive that one of our challenges is, when do we stop attending to that person in permanent housing? When are they ready to completely be let go from us so that we can take on new people? So that's kind of the, and same with employment. Once someone's working, then it's more difficult to track, because now they're out, they're gone, they don't want to see us again, hopefully, which is good. They may come back around. So it's really being able to track those long-term successes of people, and building that in is something that we continue to try to work on.
No, and I think
part of where your mind went was so great, because as we're able to build these dashboards and visualizations that populate automatically, then we can start to turn our attention to the types of questions you asked, to be able to say, well, can we find matching groups of clients, some of whom did or some of whom did not receive services, and then what type of longer term outcomes might we be able to follow? It allows us to move our resources toward these really important questions so that we can have our own kind of research database to know what works best. And that will then be able to guide future treatment so that we don't have to convince our employees this is the right way to do it. If we say, hey, look, the clients who get better, this is what they get. And our folk can see that and say, I'm on board.
Yeah, no, and well, I'll close by saying, the title of our session today was The Future Patient-Centered Care in California. I think this is the kind of model and direction that payers are going to be increasingly interested in looking at, and working with providers that can provide these types of models of service and approaches that, again, you showed your slide that showed, reduction in, ED visits in hospitals, all those types of things. But I also think, especially here in California, CalAIM, I like to say that we're really moving away from traditional case management to population health management. And this really creates a platform for starting to move into population health management. So with that, I want to thank you both. And this was a great presentation, and just can't thank you enough for joining us today. Brandon?
Thank you so much, Richard. Thank you all for joining us for today's web forum. I'd just like to take a quick moment to remind everyone that the slides and recording both will be uploaded and available tomorrow on the Open Minds website. The full Circle Elite Executive Roundtable series is also available on demand as part of the extensive Open Minds library, and it's also available on our brand new Open Minds YouTube channel as well. Please join us for our next roundtable on Thursday, June 2nd at 1 p.m. It will be a Circle Elite Executive Roundtable, the many roles of the modern CFO, the diversus health approach. This is part of an ongoing CFO consortium created to help health and human service organizations prepare their financial teams for the future, and the discussions will feature Kevin Light, Chief Financial Officer of Diversus Health. For a full list of upcoming roundtables or to register for the June 2nd roundtable, please visit our executive web roundtables under the events tab on openminds.com. Thank you all so much.